Valerie McTavish here for another edition of Experts on Call with Dr. Paul Swingle, who is a clinical psychoneurophysiologist. Now, Dr. Swingle, first off, you've already got people scratching their head. What is a psychoneurophysiologist?
Well, basically a psychologist or a physician who has expertise in neurotherapy. And that brings us to what neurotherapy is. Neurotherapy is a treatment procedure in which we correct the problems where they reside in the brain. We have a look at the way the brain functions, and we look for areas of inefficiency, and then we have some very straightforward, data-driven, naturalistic methods for correcting brain activity. It's similar in some regards to meditation. If you meditate for 20 years, you can correct some brain areas. We do this technologically in a very accelerated manner. Nothing new about neurotherapy. It's been around for the better part of 40 years. Its initial use was in the treatment of drug-resistant epilepsy, and it's FDA registered and compliant, and as I said, data-driven, and it corrects things where they reside in your head.
Just so that people aren't feeling like they have to be taking notes here, we should let them know that all of this information is on your website, which is drswingle.com. That's drswingle.com. And of course, anyone wanting more information can also give your office a call, which is 604-608-0444. Today, we wanted to take on a topic which I think is very relevant to a lot of parents who are sending their kids off to school, 2 weeks into school now, and may be noticing that their kids are developing some behavioral problems. Now, terms like ADD and ADHD are terms we've become very accustomed to hearing when it comes to behavioral issues. And a lot of parents are concerned that this might apply to their child. So just to kind of backpedal a little bit, what is ADD and ADHD?
ADD and ADHD refer to conditions in which the child has difficulties sustaining focus and attention, difficulties with hyperactivity, difficulties with distractibility. And then there are some other aspects of ADD, problems with planning, organizing, sequencing, following through on things, motivation, and so forth. Now, ADD and ADHD are what we call wastebasket diagnoses. Anytime a child is having any difficulty, they're thrown into this basket and usually medicated. The last two programs I did on CFUN, one of them was focusing on traumatic brain injury in children, which mimics a lot of the conditions of ADD. And a lot of parents are not really aware of the fact that their child may have some brain injury, which, of course, we treat, and it's correctable. The other condition, the topic of the last broadcast, was emotional trauma in children. Children who are traumatized, either bullied or some other emotionally traumatic experience, of course, they can't pay attention in school. You know, they're distracted, they may be fearful, and so forth. So the bottom line is it ADD or is it something else? And maybe that's irrelevant anyway. The beauty of the brain map is we can determine exactly what symptoms the child is experiencing, what challenges, what difficulties, and then we correct them where they reside. So if a child has a particular pattern associated with inattention, then we can correct that area of the brain and bring it into normative functioning.
And this is something that parents who are recognizing these symptoms, maybe their son or daughter's best friend has ADD, or they know other people who are dealing with this who have been diagnosed. The natural thing for a parent to do is to go to a family doctor or to a psychologist who is probably going to diagnose them as ADD. So before the parent goes on to the drug, is that the time when they would want to consider seeking the diagnosis from a neurotherapist?
Yes. When your child is experiencing some difficulty, I would recommend that you do a brain assessment and see whether there's a neurological basis for it. If there is, then we can correct that. If there isn't, then family therapy, in which some behavioral requirements, contingencies, things of that nature can be put into place, can be extremely helpful. Issues associated with the school, what's going on at the school? Is the child afraid because of being bullied? Before I would medicate a child, I would examine all of these things. Mm-hmm. Now, the notion of medication doesn't cure anything in this sense. What it does is sedate or mask the symptoms, and there are huge risks. Methylphenidate, for example, the recent research out of University of Texas that there are cytogenic effects of children treated with Ritalin. This is a precursor to cancer, of course. There are liver problems associated with Strattera, etc. And all parents, I shouldn't say all parents, but parents who have had experience with their children on Ritalin know all of the difficulties associated with appetite. So the bottom line is medication is used only under very extreme circumstances as a bridge to get from place A to place B. It is not a method of dealing or coping with this. Now, psychologists often make the same mistake, in my judgment, and that is they have parents spend huge amounts of money learning how to cope with an ADD child. Why not fix the problem in the first place?
So often when we're dealing with these individual symptoms, a parent's natural reaction is to want to fix it as quickly as possible.
Yes.
And in a proven way. I mean, it's become very acceptable for children who have been diagnosed with ADD to medicate.
Well, it's not only medication for ADD. In some communities in BC, 30% of the male children between 8 and 12 years of age are on a psychotropic medication.
Wow.
We're giving antipsychotics to treat behavioral problems in children. That's an outrage, absolute outrage. The notion that you're going to medicate and sedate out a behavior issue in a child. The use of antidepressants in children has gone up markedly. Now, depression can be a condition that mimics ADD. If the child is depressed, then it usually is not expressed as frank sadness. It's expressed as lack of interest, lack of motivation. And I know a lot of parents of teenage children know exactly what I mean by that. And if that is the case, then we see that on the brain map. We see that this is a neurological precursor to depression, not ADD. Mm-hmm. So we know exactly how to correct that issue.
We keep using the term brain map, and I heard you say brain analysis. Mm-hmm. Now, this is non-surgical. Can you explain a little bit about the process of brain mapping?
Sure. The brain map makes use of the electroencephalograph, the EEG. A lot of people are familiar with an EEG. If you've had a head injury, very often they do an EEG or an MRI. The electroencephalograph, the EEG, is looking at brain function. So when they come to my office, if there's been a stroke or a head injury or epilepsy, something of that nature, then we do a full brain map in which we put a cap over the head and measure 19 sites on the brain. And what that is telling us is what the brainwave activity is at each one of those sites and how the sites are talking to one another. That is how the brain is interacting with itself. For simple problems like ADD, depression, sleep problems, then we do a more limited analysis at much less cost in which we look at some of the critical areas of the brain. And again, we're looking at, are those areas of the brain working efficiently? Are they working efficiently in relationship to other areas of the brain that they have to be related to? We don't ask people why they come and see us. We do a brain assessment and then tell them why they're there. And it's definitely not business as usual. People and parents often expect to have to come in and spend a session or two telling us their tale of woe. Mm-hmm. Doesn't happen that way. I asked 3 questions. Do you have a history of a head injury in which you've lost consciousness? Have you had a seizure? And what medications are you on now? That's all I ask.
And that's all you ask. And then after you've done the brain mapping, you're able to turn around and say, this is what you've probably been noticing. These are the symptoms you're going to be presenting, and this is why.
That's exactly correct. So if it's a young child and the parent is coming in because they feel the child has ADD, ADHD, or a learning disorder, then what we do is see what form of problem the child has. There are many, many types of ADD. So after we do the assessment, I sit down, I ask the child, I address my remarks to the child. Do you have problems staying focused? Is the teacher always telling you, Johnny, pay attention? When you read, you get to the end of a paragraph, can't remember what you've read. There's a signature for that in the brain.
Wow. It's fascinating stuff. And of course, it's great that you can discover all of that. What we want to find out is how you can treat it. And we're going to get to that very shortly, where we're talking about ADD and ADHD and how it can be treated with neurotherapy. We're here with Dr. Paul Swingle, and his website is drswingle.com. That's drswingle.com. If you've been listening and you'd like more information, you'd like to have a chance to talk with Dr. Swingle, his office number is 604-608-0444. And today we're talking about the very topical issue of ADD and ADHD. Dr. Swingle, we were talking a little bit about how you do the brain mapping to determine what symptoms a child might be experiencing when they may have been diagnosed as ADD, or the parent may have thought that their child was ADD, which is kind of a handy title to be able to fall back on, isn't it, for a parent?
Well, a lot of parents have a sense of relief when we do a brain assessment and we ask the child a few questions and they can see the area in the brain that's responsible for the problems the child has. I had one parent, after I did an assessment, he called me later, it was right around Christmas time, and he said it's the best Christmas present they've ever had, that the child was relieved, the family was relieved. No longer was there an issue of the child being a lazy bum, to paraphrase what he was saying. Yes, there is a sense of relief when a parent can identify what the problematic areas are.
Even though it's been around for 40 years, it is new for a lot of people. And once you have the diagnosis, once you understand what parts of the brain are maybe not firing as they should be, how do you correct that?
There are three general classes of treatment in neurotherapy. The first is neurofeedback. A lot of people may have heard of neurofeedback. It's also called brainwave biofeedback. Basically what we do is we set it up so that the child is playing a video game with their brain. When the brain is doing what we want it to do, an icon will move across the computer screen. It could be a cricket chasing some other bug. It can be dolphins diving in the water. It can be flying an aircraft. I've actually set up in my office a situation in which we can drive electric trains with the brain, getting them to start and stop. And I have a wireless dinosaur that we can make run around the floor just by changes in brain activity. I must admit I play with that more than the children do. But basically what it's doing is it's normalizing brain activity, because every time the icon is moving, the brain is doing what we want it to do in terms of focus, for example. If it's a situation with an adult, let's say we're trying to treat a sleep disorder and we're doing it eyes closed to increase a waveform associated with sleep, then the person's going to hear a tone. And every time the brain's doing what we want it to do, they'll hear that tone. Their instruction is just keep the tone on as much as possible. The second class of treatments are the brain drivers. My clinic is number one in North America in the development of these non-volitional techniques. Basically, we measure an aspect of brain functioning. Based on that measurement, we stimulate with light and sound. With adults, we add microamperage stimulation, electromagnetic fields, and so forth.
And this is all non-surgical.
Oh, yes. To nudge the brain into more normative functioning. Now, the power of that technique is we can make use of that for individuals who cannot participate in the former type of treatment. And these are autistic children, for example, adults with Alzheimer's, severe dementias, severe developmental delays, and so forth, in which the child or the adult can't pay attention to do neurofeedback. So we can use this non-volitional form to nudge the brain into more normative functioning, and then the person graduates, so to speak, to neurofeedback, which is the volitional form. The third class of treatments are essentially home-based. These are things like sounds, various devices that have a specific effect on brain activity that the person can use in the home environment. As an example, I have a harmonic that's referred to as alert. And what that does is suppress slow frequency in the brain when you have it playing softly in the background. So I have a lot of college students who use this even though they don't have a particular problem, because it makes their studying more efficient. Mm-hmm. And certainly for the ADD child, it's one of the home treatments we use. They listen to it and it just makes the homework process, for example, easier.
It's like retraining the brain. It's like a workout for your brain.
Bingo. Now, it's interesting that another aspect of what we do is referred to as peak or optimal performance training. And for folks who have watched the World Cup of Soccer, the Italian team who won the World Cup, they had a secret weapon, which was written up in the Wall Street Journal, July the 29th, 2006. You know what the secret weapon was?
It must have to do with the brain.
It was neurotherapy.
Wow.
Every member of the team was treated with, their brain was optimized with neurotherapy. A colleague of mine in Montreal was a person who who treated them. Virtually all professional athletes do neurotherapy of some form or another. It just makes the brain much more efficient.
And that's how they can get that focus, which is essentially the same premise that kids are looking for when they are showing those symptoms, which we often call ADD and ADHD. We talked a little bit earlier about this mild traumatic brain injury and how that can affect the brain's ability to function fully. It doesn't have to be a major incident, does it?
No, brain injury is cumulative. So child may have had a couple of minor knocks on the head, and then a third one, the parent starts to notice some peculiar changes in attention, hyperactivity, mood changes, and what that is traumatic brain injury. We treat a lot of traumatic brain injury. From our perspective, it doesn't really matter whether the difficulty is brain injury, genetic like ADD, or experiential like trauma. We can treat all of those conditions. There are some variances, of course. Head injury tends to take longer than genetic ADD. If we're treating trauma, there tends to be an emotional component to that. That is the trauma itself, of course. But the bottom line is, no matter what the source, we can see it on the brain map, and then we can correct it where it resides, which is in the brain.
And it's interesting that a lot of the trauma or brain injuries that occur are the kinds of things that we might just not consider to be relevant. We wouldn't consider it to be a cause and effect situation when suddenly we see some behavioral change.
There are a lot of myths that we've been operating under. When I went to school, what we were taught in medical and graduate school is just wrong, and there's no other way of expressing it. We were taught that the brain is not plastic, that you have to live with what you're dealt with. We know that's not true. The notion that if a child has a bump on the head, because they're a child, they're going to heal more quickly without residual effects. We now know that's not true. We also used to think that if it was an infant that had the injury, that was less severe than a child, say, of 8 years of age. We now know that's not true. So there are a lot of myths that we've been operating under.
I think one of the other myths is if a child falls off a swing or monkey bars and kind of bounces back, there's no physical presentation of damage, whether it's a broken arm or a broken leg. A parent tends to think that, they got off easy that time. Nothing to worry about. And they almost throw it away. They forget that it happened. So that, 6 months down the road, when the child starts to present symptoms of ADD or ADHD or other behavioral issues, the parent doesn't associate the two things as being related.
Yes, that's very common. Parents should be aware that if a child starts to show marked changes in behavior, either cognitive, that is their ability to attend, emotional, their aggressiveness, their impulsivity, things of that nature, mood states, it's time to have somebody have a look at it because there's a reason for that. Now, it may not be brain injury. The child may be bullied at school, so it may be an emotional issue.
Traumatic, yeah.
But something's going on, and the child may not be able to express it. The child may not be able to express the fact that they're being bullied for all kinds of reasons. They may be afraid of the bully. They may be ashamed at the fact that they're not standing up to the bully, or they may not put the two together. I mean, there are a lot of things that can happen here.
Because we suppress so much. And when the brain is reacting to it, you can't fight that, can you?
Well, you can correct it.
But if you don't know that it's happening, you can't really change it without taking advantage of some of these advancements in neurotherapy.
Well, of course, brain injury, you have a normal restoration period of about 18 months. That's one of the myths, by the way, that we were taught in medical and graduate school when I went through. And that is after 18 months, game over. You're not going to recover much. Beyond that, we know that's not true. We have compelling evidence of marked changes 10 years after the stroke or after the traumatic brain injury. The issue associated with parents not being aware of some of these things, again, if a parent is just mindful and sees changes in behavior, that's a flag. Something's going on.
Absolutely. We're speaking with Dr. Swingle, and his website is drswingle.com. That's drswingle.com. His office, you can reach him at 604-608-0444. I want to tell you about a live demonstration of brain mapping and brainwave biofeedback that's going to happen coming up up on October 22nd. That's a Sunday, from 2:30 p.m. to 5 p.m. at the Britannia Community Center right here in Vancouver. It is free to members of Britannia Community Center, but that membership doesn't cost much, like $3 or something. So really, it's not an expensive thing to do. It's really just to help you understand what neurotherapy is and what brainwave biofeedback treatment looks like and how it all happens. So you're more than welcome to check that out. Best to register because space is limited, and the number to register at is 604-718-5800. There's more information on that on the website, drswingle.com. That's drswingle.com. Dr. Swingle, can you explain for anyone who's just joined us, what is neurotherapy?
Neurotherapy is a treatment method in which we correct inefficiencies in brain functioning. The first step is we do a brain assessment to see where the areas of inefficiency are in the way the brain's processing information. The instrument we use is the Electroencephalograph, which is basically what people often get in the hospital, the EEG. And as I said, we're looking for areas of inefficiency. When we find areas of inefficiency, we can tell the person why they've come to see us. It's that precise. The way it's corrected is referred to as neurotherapy, and there are several different treatment procedures. The first is neurofeedback, in which we set it up so that when the brain is doing what we want it to do, a person will hear a sound or see something move on the screen. If it's a child, we set it up, say, play a video game with their brain. And by doing that, we're nudging the brain into more normative functional regions. And we have a variety of other techniques that we use as well, all designed to move the brain into more optimal regions of functioning.
And we were just talking about the public lecture and workshop that's happening on October 22nd. Mm-hmm. And you're going to have a live demonstration of the biofeedback process. So people will be able to see the result of someone using their brain to alter this, video game or a tone or something like that.
Yes, we'll be doing live demonstrations of full brain maps, partial brain maps, neurofeedback, brain driving, all of it at the session. It's 2.5 hours, so we have a lot of time to be able to present a lot of this stuff for folks.
And if people are wondering whether or not they're a good candidate for neurotherapy, what sort of symptoms are presented? What kinds of things would you be dealing with that can be corrected with neurotherapy?
Neurotherapy can address a very wide range of disorders because you're correcting it where it resides, in the area of brain functioning. So it can be homeostatic kinds of issues in the body, depression, sleep problems, anxiety conditions, stroke, closed head injury, epilepsy, ADD, quite a wide range of things. We're one of the few clinics in North America that accept very severe autistic children, for example. That's because of the brain driving techniques that we've developed.
Right. And speaking of ADD, which we've been speaking on today, a parent who's gone to a doctor and with the thoughts that their child may be ADD, but not able to get the diagnosis because they only have a few symptoms of someone who would technically be classified as ADD. Are you able to help them as well?
Oh, of course. Very often we have what are called shadow symptoms. So, for example, for a child to have a diagnosis of ADD, if they go to a physician or a psychologist, then they use what's called the DSM, which is the Diagnostic and Statistical Manual of the American Psychiatric Association. In there, for a child to be diagnosed as ADD, they have to have 6 out of 9 specific symptoms. Well, what if they have 5? So the whole diagnostic procedure is really nonsensical from our perspective. What we do is look at the brain, look at the areas of inefficiency, and correct them. And those inefficiencies are associated with specific symptom patterns. By the way, ADD is not all negative. There's a form of ADD that before we became a highly industrialized civilization, when we were hunters and gatherers, there's a form of ADD that had survival value. Just think, if you were being pursued by a predator, being highly distractible and easily engaged in hyperfocus would make a lot of sense. Mm-hmm. Similarly, we've done some work with creativity with another form of ADD, and we find that some folks that have a particular form of ADD are more creative. However, their creativity is blocked more easily by a distractor. So we work so that it doesn't affect the creativity, but we're able to correct the distraction issue.
And that's part of the problem with a lot of the medication that is administered for kids with ADD and ADHD. It kind of masks everything, doesn't it?
That's one of the problems with medication, of course. It masks the problem. It sedates the problem. It doesn't cure the problem. A lot of teachers love it because it quiets down the class. A lot of parents, unfortunately, would rather give a pill than go through the bother of trying to correct the problem and developing parenting styles that are appropriate.
I think we've come to accept with ADD and ADHD that the best you can hope for is to fix the symptom instead of deal with the root of the problem, which is why we're so ready to accept that medication is the way to go. But with what you're doing, Dr. Swingle, you're really getting to the root of the problem.
We correct the problem where it resides, yes. We correct the problem rather than developing coping or sedating or masking mechanisms. You know, with something like ADHD, the hyperactive component, it's hard for parents and folks to realize that it's painful for the child to sit still. It's not a choice the child is making. The child's not being disruptive. The child's not being defiant. It's painful for the child to sit still. That's why Ritalin works, because Ritalin is a stimulant, and it stimulates the brain so the child doesn't have to self-stimulate, which is what the hyperactivity is all about. So if we correct the brain area that's associated with that hypoactivity in the central nervous system, then the child quiets down without the medication, without the amphetamines and so forth that are so risky.
It's fascinating stuff, and it is new information for a lot of people. And in talking about ADD and ADHD, I think that a lot of parents today are dealing with this sort of guilt factor. They feel like it's something they've done, whether it's the food they're feeding their child or the lack of attention and that sort of thing. So when they come to you, do they have an expectation that you're going to tell them something about their child that they don't want to hear?
No, I don't think so. They may be surprised when we see something like a trauma signature, and that's a very delicate issue, kind of a hot potato. If I see a trauma signature in the brain, then I ask the parent about the emotional history of the child. It could be bullying, it could be severe family conflict. A lot of things can do that. Very often parents are not aware of the traumatic conditions that the child is experiencing, or sometimes they tend to minimize them. For example, in one case, we've picked up a trauma signature, and the parent couldn't think of anything that would give rise to an emotionally traumatizing situation. I got a call about 2 days later from the father, and he said, I know what it was, or at least I think I do. The child was running around with a pencil in her mouth, fell, and the pencil tip and went up into the upper part of the mouth. She was taken to emergency and, it was corrected and so forth. And although unpleasant, the parent didn't think in terms of traumatic terms. But it turns out the little girl had seen a movie the day before, or a couple of days before, in which a child had died because of something penetrating the roof of the mouth. Oh. Okay? So there's something that the parent just absolutely missed. The brain showed a trauma. The trauma was interfering with normal brain functioning, so we were having the behavioral consequences of that trauma.
Parents may forget that a child might not be able to put two and two together and be able to articulate that.
Absolutely.
Dr. Swingle, I want to get to our call, Teresa here. Hi, Teresa. Welcome to Experts on Call.
Hi. My little grandson lives with me, and he's 11 now. Been diagnosed with ADHD about 5 years ago when he came to live with me. Now, if what Dr. Swingle is talking about the brain function and it being able to be corrected, why hasn't my doctor mentioned that, or why haven't I read it on the internet or any books that I've read about ADHD?
That's a good question. Why is it not up on the radar? In the United States, it's an FDA-registered and compliant treatment. A lot of physicians do it.
Okay.
Here in Canada, or I should say in Vancouver, there are some people who are running franchise-like operations, one size fits all, and I'm not very pleased with that. There's only one other registered and certified practitioner in the province besides several people in my office. Why is it not up on the radar? Well, one issue is a ton of gold is worth about $6 million. A ton of Ritalin is worth about $26 million. So I think there's an important aspect associated with issues of money and politics and that sort of thing. As we used to say in academic life, I come from a background of being a professor, that the issues are not science, the issues are politics.
Which most tend to be nowadays.
I'm afraid you're right.
But I'm wondering, I have two other children that live with me, two of my other grandchildren, and he had to be put on Ritalin because it was dysfunctional for everyone.
Oh, yes.
Like his sisters wouldn't even talk to him. They would call him retarded and call him names and stuff. And since he's been on Ritalin, when he needs his medication, you can physically see the dramatic change.
But I bet, Teresa, you would like him to not be on Ritalin.
I would love for him not to be on Ritalin.
Well, you might be a good candidate for neurotherapy. Or your grandson.
Or my grandson.
Yeah. You know what? Let me give you the office number again, 604-608-0444. And of course, if you want to find out more, it's on the website, drswingle.com, drswingle.com.
I will. Most definitely. Thank you very much.
Thank you for your call to C-Fun today, Teresa. ADD and ADHD is a problem that we are seeing more and more, and it's surprising for people to hear that there's another option besides the drugs. We're talking about ADD and ADHD and how neurotherapy can help kids with these symptoms. And we wanted to get right to Sarah, who has a question for Dr. Swingle. Hi, Sarah.
Hi. Good morning, Dr. Swingle.
Good morning.
I'm phoning because this happened several years ago. There was two young brothers, and one was on his knees by his bed playing a flute, and the other little brother came from behind to play, not realizing he had the flute in his mouth, and he sort of, grabbed onto him, and it poked a hole in the center of his mouth. It bled like crazy, and he's an adult now in his 40s, but we just wondered, could that still have some effect on the personality or anything else, or can the brain picture show that did any harm or something?
Well, brain injury can affect personality and behavior for long periods of time, yes.
But if it just goes through the roof of the mouth, would that touch the brain?
No, not necessarily.
I didn't think so. No.
It's not a physical harm to the brain, it's the trauma of the event.
My guess is that, and it's probably long gone by now, but trauma also can be cumulative in a sense that, you have a number of these kinds of things and it shows up on the brain map. But children will always go through this kind of thing. I don't mean to catastrophize. All children go through various emotional kinds of challenges and so forth. But when we see it on the brain map, that means that we have a behavioral effect of it. So that's why it's of importance.
How do they see it? Is it through MRI or how on the brain map?
It's an electroencephalograph, and there's a particular waveform that is suppressed by trauma, emotional trauma. The behavioral consequences of that is it affects short-term memory and it affects creativity. Those are the major implications of the trauma signature.
So because this person's older now, if they had that done, could they see if it left a bunch of a trauma there?
Oh, yeah, sure.
Yeah. And if it did, is there anything, if it affected their way of thinking or personality or anything else, can that be helped?
Oh, yes. We correct the neurotherapy, and then if necessary, we do some psychotherapy or counseling or whatever is required to help the person resolve these things.
Yeah, because they seem to have a different attitude about certain things. And I just wondered if maybe that has something to do with it.
Possible.
Yeah, and that's a good point. And Sarah, thank you for your call today. It's a good point because we have been talking about ADD and ADHD and specifically about children, but certainly it's not just people who are presenting behavioral problems who can benefit from neurotherapy. It's also people who want to gain focus, who may be having sleep problems, other issues that arise.
Yes. As I said, we treat a very broad range of conditions. Speaking of sleep, a child who has a sleep problem very often presents as ADD in the classroom. So it may be a sleep problem we're correcting, or a family dynamic pattern in terms of the child's not getting an adequate amount of sleep because of the structure in the family.
Yeah. And these treatments, each child is different, the number of treatments that are required?
It varies considerably. If it's simple ADD, which is one area of the brain that's not functioning efficiently, that's about 15 to 18 sessions. If it's some of the other forms, they can go up as high as 40 sessions.
But once the brain is returned to firing on all cylinders, if we could use that terminology, it's permanent. It's
That's
not
right. Once
like
it's
a
fixed,
constant.
it's fixed.
All right, great. Well, we've been speaking with Dr. Swingle. We'll have more with him coming up on Experts on Call, but I want to tell you quickly about the public lecture and workshop that's happening October 22nd. That's a Sunday at Britannia Community Center in East Vancouver from 2:30 p.m. to 5 p.m. and space is limited. So if you're interested in seeing how biofeedback works and what brain mapping looks like, you want to give them a call and register your spot, 604-718-5800. And of course, you can get more information on the website, drswingle.com. That's drswingle.com, or through their office, which is 604-608-0444. Doctor, we've been talking about ADD and ADHD today, but of course, neurotherapy helps a variety of different disorders and issues that people might be dealing with. So many people think they just have to get through it. So many people think that what's going on with them is something that they should be able to soldier through.
Well, there's some truth to that. For example, if somebody comes in with depression, if it turns out that it's reactive depression, a death in the family, for example, we don't want to do anything about that. We might help them a little bit, but you don't want to suppress that out. You don't want to change the brain activity because the person has to go through the grieving process. You know, that's the normal process. It's a big mistake we make with medication, medicating reactive depression, grievance, for example. The consequences of that can be rather important and rather severe, so you don't want to medicate out, a normal process. If the person has a genetic predisposition for depressed mood states and comes in a grieving state, we might correct the predisposition, which is a neurological condition, but not affect the other conditions. So that's the beauty and the precision of the brain mapping procedure. We know precisely what's going on and where in the brain to go to fix it.
And I mean, the great thing is you can pinpoint that, whereas someone might not be able to tell you.
Correct.
Or may misunderstand what their symptoms are. And speaking of depression, I understand that's going to be your topic on the next show, which is October 15th.
That's correct. We're going to look at the various forms of depression and what we can do about them.
We've given people a lot of information today, and I want them to know that this information is also on your website, along with a lot more information, which is drswingle.com. That's drswingle.com. And if you've been listening in and you're thinking that you might benefit from this, your child might benefit from this, the best thing to do is give the office a call, 604-608-0444. That's 604-608-0444. And they can certainly provide some more information and get a real sense of whether or not a child might be a candidate for neurotherapy.
Yes.
Coming up, we also have a workshop and public lecture. Dr. Swingle will be presenting a live demonstration of brain mapping and brainwave biofeedback, which is fascinating to see, and it'll give you a chance to learn more about neurotherapy and brainwave treatments for many conditions, not just ADD and ADHD as we've been talking about today, but also autism, learning disorder, mood disorders, even seizure disorders.
That's correct.
Coming up on October 22nd at Britannia Community Center, which is on Napier Street in East Vancouver, from 2:30 p.m. to 5 p.m. And you should register to reserve your space. The number for that is 604-718-5800. Dr. Swingle, thank you so much for sharing this information with us today and for being here on Experts on Call.
Thank you.